Hi, good morning. I am Dr. Sridhar Kalyanasundram, consultant neonatologist and pediatrician. Welcome to my channel. One of the most important problems that parents face in children is constipation. So in this video, we'll have a quick overview of what constipation is and how to approach it. As I said, this is a quick overview. It's not an exhaustive analysis of the topic. So firstly, how do you define constipation? So we have a regular stool pattern which is partly dictated by your habits, by your diet, by your fluid absorption in the gut, and also partly by your previous experience. The gut microbiota that we have, the different healthy bacteria that colonize our gut, play an important role as well. So the normal stool pattern in a baby is quite variable, as we have discussed in the previous video on what is the normal stool pattern in a baby. I would put a link for that here as well. In a breastfeeding baby, the stool almost never gets hard. So if you're exclusively breastfeeding, you don't have hard stools, and it's almost never constipation. Even if the stool frequency is reduced to say once in 5 to 7 days, it's absolutely normal if the child is comfortable. This is because digestion process is much more efficient. The gut microbiota you have is much more friendly, and the baby is comfortable with a less frequent stooling pattern in most of such cases. So you don't need to worry about less frequent stooling in a breastfeeding baby. In a formula fed baby or a mixed feeding baby, if the stool is hard, you consider increasing the ratio of breast milk, because breast milk is obviously more friendly to the gut. If you can't do that, you may consider giving a little bit of prune juice or sips of water to the baby even before you start weaning. So that's the only situation that you consider water in a baby, where there is hard stool when you're formula feeding the baby. And if that alone doesn't help, you may use a little bit of lactulose. One of the warning signs we get for significant constipation is where we have a worry of Hirschsprung disease. The baby does not pass stool for the first 24 to 48 hours, and when you do a perectal examination, there is an abrupt gush. The rectum is empty, but the stool comes down. So the anus is empty and the stool comes from the impacted stool. Hirschsprung disease is a movement disorder where the gut lining lacks the muscle cells innervation. So we have the lack of ganglion cells, so to speak, in the muscles, and this lack of innervation leads to failure of the sphincter to relax. So this is a surgical problem, and you need a biopsy to confirm it after a barium enema. And if you have contrast enema, I mean, so if you have confirmed Hirschsprung disease, or if you have a suspected Hirschsprung disease, a surgeon needs to be involved and you need to operate. If you don't diagnose the problem in the right time, it may lead to what we call Hirschsprung enterocolitis, where the dilated gut leads to bacteria getting into the bloodstream. The baby may become septicemic, and it's a life-threatening process. So where you have delayed stooling in a baby and there is abdominal distension, you have to take it seriously. You have to refer quickly and take the appropriate steps to treat. So this is one reason for pathologic constipation. Most of the constipation that happens after the infancy is functional constipation. So there are situations like, say, an antibiotic use or a travel to a different place which changes your gut microbiota. There may be changes in your diet. For example, when you're starting the weaning, if you don't give enough water, the child gets hard stools. When they pass hard stools, you have pain, and the pain and the straining may lead to even a fissure or a crack in the anal area, and the child starts holding the stool. Once they start holding the stool, the water in the stool gets absorbed more, and it becomes more dry, so it gets even harder to expel. So it becomes a vicious cycle where the child doesn't want to pass stools and they start holding the stool. So this withholding behavior is often evident. They were squirming, they're tightening their thighs, they're rocking back and forth, anything they can do to avoid passing the stool, but the parents may actually perceive it as straining to pass the stools. If it goes beyond a certain level, if it's not recognized, then stool incontinence may start, because the rectum gets distended more and more, and the stool, the undigested food particles that come from above can actually come through the sides, and they may leak. So actually incontinence and soiling are quite distressing symptoms, and that happens in more persistent functional constipation as well. 95% of constipation is functional. We have medical criteria, the Rome criteria for diagnosis of constipation, and that involves having hard stools, having stools that are difficult to pass, very bulky wide stools, and fissure, signs of fissure or cracking. And in the older kids above 4 years, you have the stool incontinence. In the younger kids, stool toilet training is variable, so they've defined 4 years as a cutoff. So if you have features of infrequent stools less than twice a week, and if the stool is hard, difficult to pass, if there is encopresis or the soiling, stool passing around, so these are signs that it is significant constipation. So the mainstay of approaching constipation is to rule out pathologic causes. So you have hormonal factors like thyroid deficiency, which can lead to constipation. So you would have suspected it from the newborn screen or later on. So it's better to get that done if you don't have. Celiac disease rarely can present as constipation. If you have a family history or if you have other features like bloating, failure to thrive, and so on, you may consider doing that as well. Celiac disease is gluten or wheat insensitivity. We also have cystic fibrosis, where you have lack of digestive enzymes and you may have constipation as a result of that. As I said, only 5% of constipation is pathologic, and majority of them are surgical causes like Hirschsprung disease, which if you have not picked up early, it might present later as well. You also have functional constipation due to gut motility disorders. So this usually runs in the family, where the intestinal motility is low for some inherited reason. So the ganglion cells may not be firing appropriately, and so the gut is sluggish. You have to manage that by increasing the dietary fiber, increasing the water, and you need to maintain the treatment in such cases long term. Most of the functional constipation happens around times of stress. So it may be due to toilet training, it may be due to birth of a sibling, it may be related to a travel, it may be related to change in their diet, it may be related to school starting, and so on. So you look into the stressor factor as well, and don't push them to toilet train when they are constipated. If a sibling has come, make sure that you are giving enough attention to the child so they don't feel sibling rivalry as well. So these emotional aspects are important to be dealt with. One important point you need to remember is that you have to remove the fear of stooling. So that's the main thing, and we shouldn't allow the fear to come back as well. So once you disimpact the stool with medical management, you maintain it, you watch the stools on a regular basis, encourage a regular toilet pattern so that the stool retention doesn't happen, so the stool doesn't get harder with time, and maintain it. So increase the dietary water intake, increase the dietary fiber intake, encourage healthy eating, avoid junk food, because junk foods are mostly processed and they are absorbed very well, they'll have very little fiber in them. So it's very important to encourage healthy eating habits on a long-term basis. The whole family should change. This will encourage the child to change as well. Avoiding excessive chocolate, sweets, and crisps and so on is better. You can use whole grain bread, you may use nuts. Nuts are a good source of fiber as well, and mashed peas, mashed sweet corn, these are good foods. As the child gets older, sweet corn can be eaten whole. In the younger infant, the baby foods, after 8-9 months you can start giving mashed corn, mashed peas, and so on to improve the fiber. Water should never be missed, because water is a very important source. Juices are overrated. Some juices like apple, pear, and prune, they are very rich in sorbate, which improves the water content in the stool and makes it easier. These can be used, but remember that juices are acidic and they are also sugar containing, so they may be damaging for the teeth. When you approach treatment, you have disimpaction measures, and we are moving more and more away from irritants and enemas. So most of the treatment can be done with oral treatment. Glycerin suppository is a harmless way to start the process, and you can first soften the stools with either lactulose in the younger infants. It's usually given before brushing the teeth, so that the sugar in the lactulose doesn't affect the developing dentition. Remind the parents to clean the teeth every time they use lactulose. It's a safe medicine. Even though we say it's 1 ml per kilo, you can give a higher dose without any side effects. The most important thing to watch for is the stool becoming softer. So if you have started with a lower dose and it's not enough, you can easily double the dose and then lower it again when the stool becomes softer. Polyethylene glycol or macrogol is a very important component that has come up in the past 15-20 years, and it has become the mainstay of treatment because it's non-absorbed, it's safe, it's well tolerated. The bland taste may be an issue, and recently we have pediatric macrogol preparations with added fiber as well, which improves the stool output. So these are usually used from 2 years onwards safely, though in my experience I've used it more than 1 year of age if the child is able to tolerate. So under 2 years you prefer lactulose, and over 2 years you prefer macrogol based preparations like Movicol, Miralax and so on. These are polyethylene glycol. They are not absorbed, they are not toxic, and the dosage in the disimpaction phase you may use a higher dosage for 3 to 5 days. Once the stool becomes softer, you reduce the dose, and then once you reach a reasonable level of stool pattern, you can use a maintenance dose of even half a packet a day of Movicol pediatric. The suppository can be used in between, but don't encourage using it on a regular basis because that's invasive and the child may start having a negative perception to it. If they have a crack or anything, it may hurt them. So don't use a suppository if there is an anal fissure. Lubricants locally, pain relief locally may help. Wait for the child to pass. When the stool becomes reasonably liquidy, they are not usually able to hold it, so they will be able to pass it. Once they reach that, have a behavioral support system like a sticker, or when they sit on the toilet every day after breakfast, for example, when the gastrocolic reflex is active, they are more likely to pass. Senna, Bisacodil, these medications are available. Magnesium, milk of magnesia is available as well. So these are conditions you can use. Anti-constipation milks which have a little more magnesium and lower calcium content, a slightly modified fatty acid composition, so the calcium binding is better. These are available. Formula milks are available, but reducing the milk intake in an older kid also reduces constipation, as the overall tolerance to liquid diet is better. So yogurt is a good product. Probiotics can be considered in some cases, however it's not guaranteed that it will work. If the constipation is following an episode of antibiotics, for example, it might help. When you change homes or when you move to a different location, the dietary changes related to that as well as environmental changes may produce a functional constipation, so watch for it. Maintain the fiber intake during those times. You do get dietary fiber in the pharmacy as well, which parents can take. So the mainstay, to summarize, is that functional constipation is the most important reason. Very rare to have severe problems which need immediate treatment. If you have not picked it up in the newborn period and it's not in the family history or anything like that, there is no warning signs like poor growth, it's important to think of functional constipation, treat it, and consider investigating if needed. The gastroenterology referral is not routine if they respond well to the treatment. So you may consider gastroenterology referral where you are stuck despite your treatment measures and where you think additional investigation may be needed. So I hope this summary is useful to you, and please do share. I will put a link to the NOVA criteria, Rome criteria for the diagnosis of constipation as well. Thank you.